Hello, hello, testing, testing.
So we got, okay, great, awesome.
I'm just gonna put this a little closer.
Sure. So it is so rare for me to have to list my disclosures because basic science lab, like basically none of my disclosures matter, but for here, this does. So I sometimes get consulting fees to consult on vaccination things. None of my funding for my vaccine research comes from industry, all of it comes from public sources. And I'm also on an unpaid volunteer position with the Lung Health Foundation where I help develop their strategies, especially around respiratory infections and vaccination, but other elements of lung health as well. I'd like to acknowledge that the Firestone Institute for Respiratory Health is on the land of the Haudenosaunee and Mississauga peoples. I would also like to acknowledge that colonization has contributed to an unequal burden of lung disease and respiratory infections in Indigenous people. And we'll circle back and talk about that a little bit later. So it's so intuitive that it's a good idea to prevent infections in people who are living with chronic lung conditions. This is one of a famous chart that almost everyone uses in their talks about COPD, which basically says that once you have a hospitalization for an exacerbation, there's sort of an immediate decline and increased risk of multiple hospitalizations. And for those of you who do asthma as your primary research focus, you know, the corollary of this is that the first line of every one of your grants is asthma exacerbations for infections are a major cost to the healthcare system. So despite the fact that it's something that's immediately apparent, I'm going to show you some pretty shocking statistics about how well your patients are likely vaccinated. That one.
Yeah, I'm just taking you out of presenter view.
Sure.
What slide are you on?
But the next one's fine. I'm gonna have to talk real fast to get through other slides.
Good. Okay, you can keep talking. Okay, I was going to share it to you.
So here are our most current data on vaccination rates. So interestingly, influenza vaccination, the goal in Canada is actually to have 80% of people over 65 vaccinated. We've never got higher than 70%. The goal to have 80% of people under 65 who have COPD and asthma is 80%, and we've only got 44% of those people vaccinated. And the stats are, that's sort of the best one. So if we look at pneumococcal vaccination, shingle vaccination, and certainly COVID vaccination, we've never hit any of our goals for getting vulnerable populations vaccinated. And I just want to draw your attention to two things that this really illustrates. Is when most people get vaccinated, it's because they hit their age target, not their disease target. And so that speaks to the fact that there's not enough awareness about our vaccination rules for people who have chronic conditions. And I also want to draw your eyes to under shingles and pneumococcal vaccinations there. You'll see one chronic condition and two or more chronic conditions. And there is a slight but statistically significant decrease the more medically complex a person gets. Would anyone like to take a guess about why that is? Why do people who are more comorbid and have more chronic health conditions, why are they actually less likely to get vaccinated than someone who doesn't have that? Go ahead, Dr. Cox.
We all need it to the other person.
Exactly. That's exactly right. So more specialist care, less family medicine care, and everyone thinks it's somebody else's job to have the vaccine taught. And so that's honestly the answer. So Dr. Cox is wise, and this is why it's not always bad to get older. Now I'm going to go through a couple of these, but the COVID vaccination rates, I'm going to point, oh no, you guys are on presenter. I'm just going to leave it because I don't care. Is that okay? Thank you. Except now my slides won't advance, so maybe I should care a little bit more.
You go over it.
There we go. Okay. Apparently, if I switch it to presenter here, it goes off in the Zoom meeting, whatever. All right. So here's my question to the audience, no judgment. How confident are you that you know which vaccines our National Advisory Council on Immunization recommend for people living with chronic lung conditions today as a 2024-2025 season? I would be shocked. Okay, one person. Good, good. Are you studying for something?
Reviewing the facts.
Good. I'm so pleased about that. Okay, now here's even a harder question. How confident are you that you understand the recommendations for your pregnant patients, for the caregivers and families of your patients, which are included in these in some cases, for people who live in congregate living such as retirement homes, for your unhoused patients, and for your Indigenous patients? Anyone? Did you even... was anyone aware that there were specific recommendations for these groups? Yeah, Josh was, because we talk about these things a lot. But I just, I want to use this to illustrate the fact that, Sophie was, good, Sophie, good job. I just want to illustrate that there is a lot of complexity in these rules, and I don't think it's the fault of anyone who's practicing medicine to not understand them, because of the incredible complexity of how we review these things. So this next slide is sort of an infographic from Health Canada. So this is how vaccine approval happens in Canada. A company who has a new vaccine will submit all the data to Health Canada. Health Canada has independent reviewers. They look over them and they make a decision as to whether it's safe, but they don't make a decision about effectiveness or who should get it. Sort of in the middle of this process, that moves over to the National Advisory Council on Immunization. So the mandate for the National Advisory Council, or NACI as we call it, is pretty simple. It's to provide advice to the Public Health Agency of Canada to make some decisions. In 2019, though, there was sort of a uniquely Canadian addition to this. In 2019, it was decided that in addition to just providing data or providing advice about which vaccines and who would best benefit from them, they should also make some judgments about the economics of who gets vaccinated, the ethics of who gets vaccinated, equity, feasibility, and acceptability. And this was quite controversial at the time because the expertise needed to make a decision about how well a vaccine works versus how equitable its distribution is are really two very different sets of data. And to be perfectly frank, the COVID pandemic was the first real test of this system in a real way. And I'll show you how our uniquely Canadian approach to doing this actually has shaped some of our vaccine recommendations. Now, because of the way we make decisions about vaccines and because of who is involved in paying vaccines, we get some pretty odd decisions made. So the National Advisory Council on Immunization makes the recommendations. But with the exception of pandemic times and the COVID vaccines, the provinces all procure, basically, they buy the vaccines. And of course, each province, based on its size, has different buying power. And vaccination, it falls under public health, which is like less than 1% of our healthcare budget. So they're all working under really tight budgets. And so it may surprise you to hear that oftentimes the vaccines that are available to your patients or yourselves are not the best vaccines, are not the vaccines that are recommended, but the ones that the provinces decide to pay for. So I've highlighted BC and Alberta here as an example. The live attenuated vaccine called Flumis, the one your kids might sniff, God sent to parents because it doesn't involve needles. Way more effective, longer lasting protection, better for kids, but only these two provinces pay for it and have it available in their formulary. The rest of the provinces, because it's more expensive, have decided to go with the needle one. Guess which two provinces have higher uptake of influenza vaccine for kids? It's the two that have the easier ones, right? So a lot of times the decisions they're made are based on cost, not effectiveness. And this is a huge issue for people who do communication in this, because it's really hard to say, yes, you should absolutely go and get your RSV vaccine. You have to pay for it, but it's like totally a good idea and your doctor thinks it's important. Now, I find the National Advisory Council on Immunization, one of the reasons nobody could confidently put up their hands here except for one person is because this is a group of people who are pathologically opposed to bullet points. Like, honestly, you have to read 5 or 6 pages to get anywhere near what the recommendations are. but I will be the hero that we need and provide you with the bullet points that you need in the form of this slide. So because we're a little compressed on time, I'm not going to read them all, but basically the recommendation, for example, for the pneumococcal vaccine, don't worry, Josh, I'll give you the slides. The pneumococcal vaccine from NACI actually just changed last week, and it said everybody should get the newest one, the PCV20. Everyone should get it. But what will our province pay for? Well, our province will not pay for it if you've already had the less effective pneumococcal, the 23 polysaccharide one. And it's not clear if patients will be able to pay for it yet in the pharmacies. For influenza vaccine, it's easy. The recommendation is everyone over 2 years should get a flu shot, and they're all free, so easy peasy. COVID vaccine, again, easy. Everyone over 6 months should get one, and they're free, as long as they're mRNA. We can talk about that in the discussion if you'd like. RSV is a little bit complicated, and I want to highlight this because this isn't, like I said, the provinces get to make their own decisions, and this is an interesting case where the province of Ontario has a more expansive recommendation than what the National Advisory Council on Immunization recommends. So currently, the National Advisory Council on Immunization says it's approved, anyone over 50, it's approved and safe for, and I'm only talking adult vaccination here. Everybody over 75 should absolutely get it. Anyone who's over 60 living in long-term care should definitely get it. And anyone over 60, if the healthcare provider recommends, should get it. And on the province of Ontario now, we have, and I want to emphasize this, everyone over 60 who lives in a retirement home or long-term care. So if your patients live in a retirement community, that's considered congregate living. And congregate living in Canada is associated with unacceptably high levels of respiratory infections. And so that's an unusual case where if you know where your patient lives, they might actually be recommended to get it. Also, because of some of these equity concerns, unhoused patients and people of Indigenous or any high-risk condition are available to it. But you can also pay for it. If you have somebody over 50 plus who doesn't hit these, it is possible to pay for it, and it's recommended, it's safe and approved. Now, because it's not a respiratory infection, you might not think about shingles quite as frequently as other ones, but actually shingles is a horrible condition, both because it's difficult to treat, it makes people's lives a living misery. When I do like public talks where I'm doing like, if there's like 100 older folks and the adults, I said, oh, who got their shingles? Who has ever had shingles? Oh, which of you, put your hand down if you think getting vaccinated is a bad idea. And they all keep their hand up because shingles is a misery and nobody wants to have it again. So and there's also some long-term health issues, which I'll get to at the end of the talk. We currently have a new recombinant shingles vaccine, which is a rare case of a protein vaccine working better than a live virus vaccine. Usually it's the other way around. And so the recommendation is 50 plus, everyone who gets it. If you've already had the other version of the vaccine, you should get the new one. And if you've had shingles, definitely get the vaccine, and that is very easy to sell to people. But in the province of Ontario, you only can get it for free if you're between 65 and 70 years, and you can't get it if, for example, say you got it's a 2-doser. If you paid for your first dose because you wanted to get a bit early, you can't then go get your second dose for free in the Ontario program. And if you already had the live vaccine, even though the recommendation is you should get the new recombinant one because it's way better, they won't pay for that. You can do it for pay. So again, if you don't understand our vaccine recommendations, that's because they're all rubbish. and it's really hard to navigate the complexity of the system. Okay, so like I said, influenza vaccines are the easiest ones. And the easiest thing to communicate is actually the recommendation is everyone who's over 6 months should get one. Easy peasy. But of course, there are a significant number of people who absolutely positively certainly must, and they're sort of the people you'd predict: health conditions, older adults, pregnancy, and we'll talk about why that's so important. Congregate living, again, is so important. Even pre-pandemic, Canada had some of the highest death rates of infectious disease in long-term care and retirement communities in the OECD. During the pandemic, we had the highest rates, at least in the early parts of the pandemic. For various complicated political reasons, which we can discuss in the discussion period, it's so important. And again, Indigenous people are considered at high risk. So this is a table review that my postdoc and I are sort of putting together to sort of compare policies around influenza and COVID vaccines. And I want to show you a couple things that really make Canada an outlier in a good way this time in the OECD. So most countries do recognize that influenza should be given to priority populations. In fact, most OECD countries don't give it to the general population in the way that Canada and the US do. But most people, most OECD countries do have a pretty comprehensive influenza. And Canada, like I said, is a leader in recognizing equity-seeking groups for this. And so we are the only ones who make a specific recommendation to target Indigenous, racialized groups, other equity-seeking groups. And the biology for this is quite fascinating. I want to show you the hospitalization rates. This is American data. Most of the best data doesn't come from Canada because we've only recently started collecting race-based data. And it shows the hospitalization rates for different ethnicities: Black, Asian, I think, Hispanic, White, Asian Pacific Islander. And as you can see, certain racialized groups have higher hospitalization. This is true for influenza and pretty much every other infectious disease out there. And it's been shown very definitively that having vaccination policies that target these groups specifically and recognize them as a priority population increase uptake. So in COPD patients, as an example, in the US, about 31% of them have their flu shot, even though, of course, we aim for 80%. But that's only 21% of Black patients. And during the COVID pandemic, there's been about 1 billion publications now about how when you specifically point out and target and those groups and say, you especially need a vaccine, that increases uptake in a huge way. And so I wanted to point this out to you because in a lot of the studies, when you do break down vaccine effectiveness, actually vulnerable populations, it looks like the vaccine's way more effective. And that's simply because they have such a higher risk due to occupation, due to socioeconomic, of actually getting sick. So the people who will best benefit from these are the people sometimes who are in these priority groups. Yes, so like I said, if you actually make it specific, people actually do that. And we can have a whole conversation about some of the successes in doing that in Canada that came right out of the master here. Okay. Now I want to point out another really important population of people that we have really specific recommendations for influenza, because this influences the person who your patient brings with them to their appointment. It's informal caregivers and healthcare professionals. So many people aren't aware that for influenza vaccination, we actually have a recommendation that anyone who lives with, is a caregiver for a vulnerable group, also gets vaccinated. And the list of caregivers is pretty intense. It's basically anyone who works with a kid in any setting. So if you're a daycare worker or whatever, or you have kids, or you're the grandparent of a child, that puts you in the priority group. If you do any caregiving, people who do essential community services. And so that includes anyone who works in any outward facing profession, actually. So retail being a classic example of this. Obviously people who are in contact with chickens, we really, 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 really want them to get vaccinated right now. But we recognize informal caregiving because there is a strong body of literature showing for both influenza and now COVID that if you are vaccinated, you are less likely to get sick, obviously. You are less likely to spread that to your vulnerable family member. And if you're a vulnerable family member, you're less likely to get sick. So you can do a better job of the caregiving you need. And this is particularly important for communicating to our young people who volunteer with kids and older adults, that they actually should be getting a flu shot if they don't worry about themselves or the other people in their family. But let's show this incredible piece of data that is a McMaster success story, which has led to both Canada and the US adopting these. So our colleague, Mark Loeb, did this really remarkable study in Hutterite communities. Does anyone know of the study already? No, okay. If you in my sphere, the people I hang with, and you go to a conference and you say, oh, do you know Mark Loeb? Have you read his Hutterite study? Oh my gosh, that's such a big study. So this is like a rock star study in the infectious disease world. So what Mark did, he's the king of the randomized controlled trial, and he recognized that Hutterite colonies in Manitoba and Saskatchewan were the perfect place to do a randomization. Hutterite colonies are never more than 150 people. So if you get more than 150, you split off and you make a new one. So he had this idea, like, what if we randomized each of these colonies to a treatment? And then that would give us a way of studying this in a way that would be very hard to do in the general public. So this particular study he did, he wanted to investigate the strength of vaccinating only kids in the community. So the colonies get randomized, and they either get the influenza vaccine or they get the Hep A vaccine, and it was a crossover. So they, at the end of the study, they get the opposite one. And they only vaccinated the kids. So only the kids, I think they were under 60. And remarkably, what they found was that just vaccinating the kids gave 61% protection to the entire community. And this is because if you, for dollar, if you were going to choose between vaccinating your vulnerable patient and vaccinating the young people they came in contact with, your money would be better spent vaccinating the young people, believe it or not, for influenza. And this is because young people are the ones who get infections and pass them on to older adults. The data I'm showing you here is June 2020 in the country of Iceland. And they're looking at COVID infection rates. And it's considered like the most beautiful, pure data on who actually gets infected with COVID. Because being a small island country that had a strong sense of self-sufficiency, they were like the only place in the world that had enough nasal swabs. And at this point here, every citizen of Iceland had been swabbed an average of 3 times already. Isn't that crazy? And so they were able to actually make this beautiful curve, which was later published in the New England Journal, showing who was most likely to get infected. And what you can see is it's not the oldest old, it's younger. And now that we have Omicron, it's actually shifted even farther to the younger side of the thing. Why do young people, why are they the ones who are more likely to get infected than older adults? Well, it's because they have more social contacts. They go to school, they go to work, they socialize in ways that, Jerry, you and I, we're not getting older, but the young people here are socializing more than we are. I know it's shocking. Now in Canada, our data is obviously quite rubbish, because when was the last time anyone here got a swab? I don't think you did. And if you did a rapid antigen test for COVID, you had no way of reporting that. So there's no way we can collect that data. But even with our absolutely rubbish data, this is the last sort of snapshot we're probably ever going to get of this in Canada. And you can see, again, it's younger people who are more likely to be infected than older people. And again, this is a truism of infectious disease everywhere. It's actually young folks who are more likely to get infected than old folks. But of course, old folks are way more likely to get severe outcomes. So this is why I always say vaccination is a family affair. This is one of my favorite examples of this. This is my favorite study. These are pneumococcal infections, invasive pneumococcal disease, and you can see the seasonal pattern. So they go up in the winter, down in the summer, blah, 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 blah. And then there's these spikes where people over 55 get admitted to the hospital for pneumococcal disease. Recognize anything interesting about those dates? Anything happening around that time? Any family events that might be going on? What's that? Santa brought invasive pneumococcal disease to the over 55 crowd. That's right. So these spikes are because young people socialize with their grandparents at this time period. Now, the pneumococcal vaccine for children was brought in around 2000. And what you can see is that not only do the waves of invasive pneumococcal disease decrease in older adults, but we sort of lose these spikes for them. And this has a direct relevance to your patients, because what was remarkable, the vaccine for the pneumococcus, when it was brought in for kids, was meant to stop invasive pneumococcal disease. But the pneumococcus causes both invasive pneumococcal disease, primarily in kids, and pneumonia in older adults. And what happened after this vaccine was introduced is all of a sudden older adults got pneumonia less. And this here is the relative risk reduction. Again, there's no adult vaccination here. This is only after pediatric vaccination. This is the relative risk reduction of people who are on immunosuppressive drugs. And again, both IPD and pneumonia rates went way down after the kids were vaccinated. So you can think about this in the context. I always say vaccination is a family affair. And vaccinating the young people in the family actually has this huge indirect effect on older adults. But, and here's a big but, again, we have to think about this in the context of equity, because pneumococcal vaccine uptake historically has been pretty good. But in the last childhood immunization survey, the most recent data we have, there has been a loss of uptake in Black children and racialized kids. And what's super interesting about this is you might be thinking about vaccine hesitancy in racialized populations, and that exists in adult vaccines. But actually, racialized communities consistently show more commitment to getting their kids vaccinated. And this drop in discrepancy is attributed almost exclusively to the family physician crisis. Childhood vaccinations are done in the doctor's office, and if you don't have a doctor, you tend to fall off the chart for getting your childhood vaccines. So I put this out to you because I really like to think of things as big systems. And this family doctor crisis is affecting your patients for two reasons. One, like we said, the more complex they are, the less likely they are to have that talk about vaccination. And two, their families, especially if they're underserved or underrepresented group, are less likely to get the vaccines they need to protect them. All right, so let's talk COVID, because COVID is a nightmare. I have put these recommendations here. I'm not going to read them out to you, but you can have the slides if you like. The take-home message is, if someone says, should I get vaccinated for COVID? The answer is yes. Everyone over 6 months should get vaccinated for COVID. That's the simple answer. And of course, it becomes even more pressing if they have an addition, but it's a simple answer. Would anyone like to guess what percentage of Canadians are up to date and are following that recommendation? Just pick a number.
21.
Oh, you guys are optimists. 4%. 4% of Canadians are up to date on this recommendation. And admittedly, we are at the start of this campaign, so hopefully it's going to go up a little bit, but I am less optimistic. And I want to, I'm speaking to the converted here, but nonetheless, I need to show you this because we all need to be on the same page. The hospitalization rates for COVID in older and adults are still very, very high. The red line there, back in the day, pre-Omicron, we thought those levels of hospitalization were absolutely horrific. And yet they are equally high in the post-Omicron, post-vaccine era. This makes, now again, I want to show you, and I also want to show you our mortality. I don't believe in counting mortality. I do not like counting mortality as the most important thing about infectious disease and vaccination, because working with older adults like I do, dying is not the scariest thing. Losing independence is the scariest thing, and you don't capture that in death statistics, but I will put this out there. This I got yesterday. This is our most recent data of the causes of death in Canada. And look, COVID in 2022, this sits at number 3, and I counted all the COVID deaths reported for 2023, and it's over 20,000. So it's probably going to stay as the 3rd leading cause of death. Higher than influenza and pneumonia, higher than chronic respiratory conditions. But how crazy is it that we've got 3 infectious diseases, influenza, pneumonia, and COVID, in the top 10 causes of death in Canada? These are vaccine preventable for like dollars a shot. Isn't that crazy? I think it's crazy. And just to give you some sense about, this is Ontario data from yesterday. COVID is still way swamping, and this surveillance period is only the past month, is swamping influenza and RSV. Admittedly, we're at the beginning of the season. If you look for how many tests are positive, how many outbreaks there are, how many hospital beds are being occupied, how many deaths there are, how many reported infections there are. So if you were going to make a recommendation to only get one vaccine, and you wouldn't do that because you're good, responsible people who are going to make sure everyone gets the top quality care they need. But if you were only to make one recommendation, you would definitely pick COVID over influenza based on these data. And a population I care deeply about is the retirement and long-term care setting. And like I said, Canada's deep shame is how many infectious disease deaths we have in these communities. I can do a whole talk about why. But look at how many outbreaks we're still having. We had a world-leading cause of death of infectious disease pre-2020, and this is absolutely swamped by the number of outbreaks we're having in the COVID years. So an ongoing problem. But as someone who does a lot of communication, I can tell you, and I'm sure you've heard the same thing, if these vaccines are working, how come I have to keep getting them? And the answer for that is complicated. Now, when the first vaccines, the first clinical trials came out, they were both a 2-dose series for Moderna and Pfizer, a short time apart. And I remember at the time being like, okay, I guess we'll get everyone these 2 shots now and we'll worry about their 3rd and 4th shots later. So why would I be thinking about 3rd and 4th shots? Well, let's do a little bit of math here and let's do some counting. And I'm going to, I don't think I have a, do you have a thing? No, I don't. Okay, so I want you to, if you can read diphtheria there, count the number of vaccines a person has in their lifetime for diphtheria. They get 1 at 2 months, 1 at 4 months, 1 at 6 months, they get another one at 18 months, they get 4 to 6 years, they get that, and then they have to have boosters. How many vaccines is that? 6 on that chart, right? Virtually every vaccine to give you lasting memory, you need at least 3 or 4 shots of. If you have 1 shot, you will have a nice little temporary boost of something going on, and then it will fade away to nothing, and you lose your protection. Because our immune system wants to forget, not remember. And so if you count down, and even if you look on the right-hand side of that chart, there's 3 that look like you're only getting 1 dose. If you could read the fuzzy fine print at the bottom, you'd see those are 2 or 3 shots. So it is almost impossible to get lasting memory from a vaccine from something that you only have once or twice. That is one reason why you will always need to have multiple COVID shots. The other reason, of course, is, and I'm going to try to do something radical and do this so you can see this. Hopefully the folks, I haven't lost the folks online. Okay, folks online, tell me if you can see that. I know you're in the wrong view again. All right. Okay, so I'm going to try to do a little animation. No? They can? Oh, way to go, guys. Okay, hopefully you can see my animation. No, you can't. Okay. This was a beautiful animation of some beautiful data. So I'll just highlight it for you. You need multiple doses. So what this was is showing the duration of immunity and waning of immunity after 2nd, 3rd, 4th, 5th, and 6th doses in the long-term care setting and retirement home folks. And what you would have seen had my animation worked is you would have seen rapid waning after the 2nd dose and slower waning after the 3rd, slower after the 4th, and at 5th and 6th, you'd see that there was no waning of those responses. So repeat vaccinations are not a problem. They're just what you need to do to have your immune system remember stuff. Very hard to communicate. All right. This is what I hear all the time in public science communication. I hear, these vaccines don't even stop you from getting sick, so why should I bother? I present to you a case of the flu shot. So here what you're looking at is the percentage of protection against symptomatic infection for the various different flu seasons. And what you can see, that ranges from 10% on a bad year to 60% on the absolute best year. And I'm going to show you some data later that shows you the COVID vaccines rarely get as low as 40%, are usually 60, 70%. So they're actually better for this than flu vaccines. But we accept this in our flu shots, and we don't accept this for our COVID shots for reasons that are hard to understand. So despite the fact we have this really variable protection, this was an infographic put out by the CDC saying that, we prevented 7 million deaths and 100,000 hospitalizations, or sorry, 7 million infections, 100,000 deaths, whatever you can read. And this was in a year where there was only 38% protection from symptomatic infection. So even when protection against symptomatic infection is not great, the impact is huge. And I'll tell you the mechanisms for why. Most vaccines are better described as immune modifying rather than preventing infection. So in this case, if you compare older adults who get vaccinated for influenza and get sick, go on to get influenza, and compare them to those who didn't get vaccinated, the folks who got vaccinated are less likely to be hospitalized if they get sick. They have a shorter hospital stay, they have fewer long-term complications, including heart attacks and disability. My online group says they can see the presenter view now. I'm sorry, you can't have it both ways. You guys got the good view for the first half, now the other group does. Okay, so most vaccines are disease modifying. And this is the case for influenza, whooping cough, meningitis, pneumococcal pneumonia. You may have infections with these guys. You're probably not going to know them necessarily. But the COVID vaccine was a rare chance to actually understand the mechanisms by how this works in almost real time. So I'm no respirologist, but these are the pictures of what lungs of COVID patients often look like. And if I had, and we had words like ground glass opacity and crazy paving and stuff like that, for my respirologist colleagues, would I be wrong in saying you don't see this anymore with your COVID patients, right? This doesn't happen anymore, or rarely happens, right? And this was one of the very first things that came out of the Lancet that sort of highlighted the progression of people pre-vaccine. And most people were hospitalized on day 5 of symptoms. Okay, now this is going to require you to do some math again, okay? So in the pre-Omicron era, the asymptomatic period or the pre-symptomatic period was 5 days. Okay, so you're sick, but you don't feel it. And then you go to the hospital after 5 days. Why is 10 days a magic number for immunologists? When you tell an immunologist something happens at 10 days, why do they start getting real excited? Anyone want to take a guess? 10 days is like in all our textbooks. You get an infection, and then 10 days later, what happens?
Specific immunity.
Antibody-based immunity, specific immunity, exactly. So whenever you tell an immunologist, oh, this happens at 10 days, they're like, oh my God, that means the antibodies are part of the problem. And that is exactly what happened in the context of COVID. This, again, was an early autopsy sample that came out really, really early from China. And I remember seeing the preprint of this and saying, oh God, this is bad news. Because what they're looking at in the left there is they were seeing that alveolar macrophages were internalizing the virus. And we already knew or strongly suspected that the virus wouldn't be able to infect the macrophages. It couldn't make more viruses. But the combination of the incredible lung inflammation and seeing the virus inside of the macrophage told us that there was something really bad happening with antibodies. And so what happened was these antibodies bound to the virus, the macrophages internalized them. And as much as I love a good macrophage, when they're bad, they're very bad. And so they made a huge cytokine storm. Groups in the US were actually doing single cell profiling of people who were dying of COVID and found that there was an inappropriate inflammatory response that brought T cells into the lung. And that's really not something that should happen during an acute infection. And it turned on as this incredible circuit of inflammation that led to the requirement for ventilation.
Sorry, John, did the SARS, or whatever, sorry,
SARS-CoV-2, yeah.
did it have an antibody on us to be internalized?
It seemed to. The macrophages don't have the receptors to internalize it on its own. So it had to have the antibody.
That type of antibody would have been your...
It would have been your early and poorly made antibody, yes. And as it turned out, there's something really wonderful and wild that we learned about these early antibodies. So normally you stick a bunch, you know how antibodies are Y-shaped? You stick a bunch of sugars on this part, the long part of the Y. And as it turned out, older adults and men, when they first encountered the virus, didn't put the sugars on there for reasons that are unclear. They're called afucosylated, so meaning they didn't stick the sugars on them. And I actually got to have a meeting with the guy who discovered this. The Gardner Award winner, Jeffrey Ravitch, was at MAC the other day. And I said to him, why don't old people and why do men not put their sugars in the right place? And he was like, I don't know, Don, but I think you should work on this. Because when they didn't stick the sugars on in the right place, those antibodies were recognized by macrophages and internalized. But here's the absolute miracle of vaccination, is that, even one dose of the vaccine provided appropriate instructions to put those sugars in the right place. So the reason you don't see this as a characteristic of COVID so much is because any vaccine exposure, no matter how long ago, seems to provide the instructions to start putting the sugars on the right place, and we don't get this macrophage-mediated inflammation. We know some of the mechanisms by which vaccines modify other infections, like the pneumococcus, but we don't know for things like influenza. Crazy, eh? But we got to see this all in real time. I love teaching this in my fourth year immunology course. Okay, one thing I want to cover is a question I get asked a lot, which is like, why even bother? Like, they don't even protect you for very long. And like, what's the point of getting all these vaccines anyhow? And again, I want to point to you the waning that happens with influenza vaccines. So influenza vaccines, let's pretend it's the best year, like the best year, and you get 60% protection from symptomatic infection. Actually, they wane about 10% a month. So the reason you get one flu shot a year is not because you get a year of protection. You get, like, at best, like 3 really good months of protection. And it wanes. And I'm going to show you the data comparing both the COVID and influenza with regard to waning. I will also point out that cold and flu season is like an artifact of the North and South Hemisphere. Equatorial regions, there is no cold and flu season. And in many of those countries, the policy is actually to get 2 flu shots a year to get protection consistently over the course of the year. So and I cannot stress this enough, we get 1 flu shot a year because we live in an area that has about 6 months of flu season, not because you get a year of protection. And that's something that I found most people aren't aware of. So here, if you just draw your eyes, this is flu shots. And so we're looking at effectiveness less than 3 months there versus greater than 3 months. And what you can see is that, you get about, maybe 50, 60 on a really, really good year, a little bit more protection for 3 months. But after 3 months, that wanes. And by 6 months, it's 0 for almost all the influenza vaccines. Now, cast your eyes, this is for COVID. In COVID, you also get somewhere, 40, 50, 60% for 3 months. Then after that, it goes down. But here's the crazy thing about COVID. For the flu shot, you can only measure vaccine effectiveness against the strain the vaccine was made at, because the effectiveness is 0 against, if we have a mismatch year, you don't get any cross protection. COVID, we've never once been given the same vaccine as the variant that's circulating. We've always been looking at cross protection because we've always been a couple of variants behind. And so even though we've never had a situation where the vaccine matches the strain that we currently have, we still get upwards of 50 or 60% protection from symptomatic infection for 3 months. And that actually lasts a lot longer than influenza shots. So if we were comparing COVID vaccination to influenza vaccination on the same sort of values or merits, we would say that COVID vaccines are excellent vaccines, not that they wane quickly and not that they don't do well. And I know I'm talking really fast because I get so excited about vaccines, but I want to make a special comment about patients, especially with rheumatologic conditions, because I know a lot of you work with people who have those conditions. And I got involved in a couple studies in vulnerable populations because my dear friend and colleague Maggie Larche said to me, Dawn, what do I tell my patients who are worried about if these vaccines are safe for them? And at the time, in the beginning of the pandemic, of course, you don't put people who are on immunosuppressive medications in a clinical trial to see how well a vaccine works, because the answer would not be in your favor. So we didn't really have any specific data about that. And as well, obviously, pregnant women are always very concerned about safety stuff. It is true that mRNA vaccines have unpleasant side effects. The award winner for terrible side effects is shingles by a long shot. That's the one that has the most horrific book your day off work, plan to go to bed, feels bad. Within the mRNA family, Moderna more than Pfizer because there's more mRNA than Pfizer, and then the flu shot. So there's no point ignoring the fact that these vaccines make people feel pretty poorly sometimes. But for older adults and people who have rheumatologic conditions or on immunosuppressive medication, they often think because the infection is not safe for me, the vaccine must not be safe for me. Because I will have a worse time with the infection, ergo, I will have a worse time with the vaccine, and the opposite is true. This one I find really clear and easy, but there's similar data these are for older adults, but this is similar data for people on immunosuppressive medication. They are less likely to have side effects, many of these side effects, than the general public because they're not having that robust immune response. So, but there is a real concern about flares for people with rheumatological issues. When the mRNA vaccines first came out, mRNA looks like a virus, which is why it's such a good vaccine because it really stimulates our immune system. And viruses stimulate what's called the type 1 interferon pathway, which often goes wrong in people with rheumatoid arthritis, with lupus, with other conditions. There was a real concern that there'd be a strong type 1 interferon response in these patients would cause their disease to flare up. So I was part of a study with a whole bunch of other people across Canada to try to figure out if this was going to be the case. And in truth, what we found is that really, honestly, we didn't see a strong association with flares or safety signals. But I've been working with a number of patient groups, and they all come to me and say, no, Dawn, I had the worst flare of my life after this. I'm never getting another mRNA. When can I get one of the protein-based ones? And I don't know how to reconcile our study, which says this doesn't happen, and their real life experience, which says that does happen. And I worry that our study questions weren't designed well enough to really get to the heart of that. So I find this very difficult to reconcile. I can show them a bunch of papers and say, no, there's no flares. See, you just have more flares in the fall because infections cause flare, right? But then their real life experience is not supportive of that in many cases. So it's challenging. Okay, lastly, I wanted to make a comment about pregnancy. Partially because of all the groups of people I've ever worked with, of everywhere I've ever worked, every other institute, this one is the most fertile by far. I think we are hitting above replacement rate. So maybe this will be information that all you parents might be able to use, but also because I was remembering a really complex patient that Sarah McIsaac and Nathan Hamley presented a couple of years ago. PAH required an interdisciplinary team to get through that pregnancy. And pregnancy is a time when vaccination is so very, very, very essential. All infections are associated with pregnancy complications and neurodevelopmental issues for babies. And one of the problems is that women who have conditions which should put them in where they should get vaccinated, specifically asthma, stop getting their flu shots when they're pregnant if they aren't specifically told to. People feel it's safer to do nothing than to get vaccinated. And so even though people, with these conditions need the strongest possible recommendation to get vaccinated, many of them worry that it's safer to do nothing than expose their baby to a vaccine, which is not true. Okay, I really do want to have time for questions, so I think I'm just going to skip through a few more slides. Get vaccinated, get vaccinated, get vaccinated. But here's my evidence-based ways to increase vaccination in 10 seconds or less for the busy clinician. The most easy thing, and it's been shown to be highly effective, is if you're writing a prescription, you say the sentence, when you pick up this prescription, book your COVID and flu shot. So easy to say, and it does increase people's uptake because they see that as being part of their prescription. Easy step one. Should I get vaccinated? Of course you should vaccinate. Everyone should get vaccinated. Second, evidence-based thing, completely consistent with the NACI recommendations. You don't have to have a long conversation about that. Alternatively, if you were a member of my family, I would definitely want you to be vaccinated. People really respond to that. And the last thing that in the pre-pandemic days, we didn't really have this thing called virtue signaling, but I think that's what we have now, where is if people have signs, stickers, buttons that saying I got vaccinated, their patients are more likely to get vaccinated. So those are 10 super evidence-based ways to increase vaccination rates in a way that doesn't require too much time or effort. And I could do a whole thing. So I always, whenever I present any data from the long-term care study, I need to acknowledge these folks. I only showed you one graph, and I always like to give these folks the last word, as they were the people who gave the blood for that study. But I have a couple minutes and would love to answer any questions that you have. Oh, questions online? Any questions online?
Any comments or questions from our audience here? As you see, Nathan.
First of all, I want to thank that was an amazing talk, and definitely asking for your slides of like notes here as the things something that we're really pushing hard for a lot of patients, the generalists, specifically on immunosuppression, and so having a more tailored approach to this that we're really trying to hear as part of the day-to-day process. Right? My question is, young people who are on immunosuppression, I often get letters back from the pharmacy saying that they're not eligible for 35%, or they're not eligible for these sorts of things. I'm sending them prescription telling the patient that have to be able to talk to them, but the pharmacies aren't actually administering vaccination. It's like back do you have is this evidence-based, or is this just that?
It's totally evidence-based because, you know, there's this guy we should come and give the talk here. He's a pharmacist. He does a lot about like vaccination in pharmacies, but also like the health economics of who gets vaccinated in a pharmacy and how much risk pharmacists are willing to take. And so effectively, to sum up one of his amazing talks, invite you here to have this conversation, it's you have to find a pharmacist who's super well educated and I actually never say like, oh, because even though the recommendation, I mean, communicating these things is always challenging. It changes every 6 months, and you have to find the right people to do that because it's allowable. It's totally allowable. Any of the nasty recommendations, you will always see, even in the province of Ontario, at the healthcare provider's discretion is always put in there because you don't want to override clinical judgment. And there's all the pediatrics, a classic example, where kids who are really medically complex and don't have the list are still often fall into that range where they need to get vaccinated, but you got to find the right provider. I'll reach out to Michael. He's remarkable. He's really, really great.
There's a question there about why can't we make better, more effective vaccines?
So it is unreasonable to expect sterilizing immunity from things that you've evolved to evade sterilizing immunity. So our childhood vaccines unfortunately gave us some weird expectations about what we can and cannot do. But anything you've had more than once in your life, which is any respiratory infection, has evolved to evade that. And we cannot our bodies are not made to keep the levels of neutralizing antibodies and T cells at maximum all the time, because we need the space to put in more things. We all have a homeostatic level of how many antibodies are in our blood and how many white blood cells are in our blood. And so to keep them high enough just for COVID would have to sacrifice something else. So all influenza, RSV, COVID, human metapneumovirus, parvovirus, et cetera, any virus you can think of, you can actually get them in the same season, the seasonal coronaviruses, because that waning, they live to take advantage of that. So we can't do it because it can't be done right now. And I have high hopes, though, for the inhaled vaccines, because it's possible that our lungs have some more capacity to keep neutralizing IgA at levels that will be more effective.
On the issue of mandatory vaccine, so how mandatory is the vaccine for us who work in the hospital? I receive exhortations to get vaccinated against flu and COVID from the medical staff and on email. What if I chose to be awkward and ornery and had my reasons for not? What's the balance there about people in the front line delivering care and the hospital bylaws and things like that?
So vaccination sits in this weird space between personal health decision and public health decision. So lots of public health things. You're not allowed to pollute the water. You're not allowed to like throw E. coli down the drain or whatever. And so vaccination sits in this weird space because you absorb the risk, because all vaccines have risk as a person. But how much do you have to weigh the public health around that? The data is pretty strong that healthcare places that prioritize influenza have less influenza, and they have less other infections too, because of course, influenza comes with a secondary bacterial pneumonia risk, et cetera, et cetera. So that data is really strong. The data is increasingly strong for COVID, but we haven't been able to implement that right now. So the rules, like the employment law says, if you enter a job with rules X, you are accepting those rules when you take that job. And where COVID's been really problematic is, of course, you were not hired when there was a COVID vaccine. So, I mean, I think it's the responsible thing to do, but it's not, it's extremely controversial right now.
So I can object on my own grounds and not be kept out of work.
For COVID now, yes. For influenza, no.
So I'm just interested in barriers to uptake the vaccines. And sitting there, probably being a Roman Catholic, I thought it was my fault that we weren't doing enough to encourage our patients. But other than us being advocates for vaccine, whatever obstacle that might address, what other obstacles are there? Any other obstacles out there that we should be aware of? Or what's in theory, what's the opposition to getting vaccines?
So truly hesitant people, the vociferous people you see online, are a minority, and almost none of the people actually, it's funny too, because when I do things for like the general public, I get those people come to talk to me. When I do talks for specific populations, like the people who are here, I never get those people. So there are people who are worried or concerned, but I don't really think you have to worry about truly vaccine hesitant people. People just have questions and they don't know. And how fair is that? I mean, I asked at the beginning to put up your hands if people felt confident here. If we don't know, how can we do that confidently? So one of the reasons I always try to explain how things work is because it's also been shown that the more not confidence a person has in why these decisions exist, why we need to get these repeat vaccinations, the more likely the people in their care are to get vaccinated. So knowledge is power, I guess. But the family doctor crisis is huge. I will say that.
Question about
Yes. So many countries actually have their healthcare work. So you guys are the guinea pigs for this, because healthcare workers are the ones they do all these studies in. You're way more likely to get sick at the end of season than the beginning of season for influenza, because you're outside of that 3-month period of protection. So many countries actually recommend 2 doses for their healthcare workers, or in years where the influenza season is particularly protracted, the hump is longer, than getting a second dose. In Canada, we don't do that, but some places do. And there's something else I was going to say about that. Ironically, I just got my flu shot. If it were up to me completely, I would get my flu shot in December to carry me over when flu season starts in January. The reason I get it in November is 2 reasons. One, if I'm ever on TV or anything like that, I don't want someone to say to me, have you got your flu shot yet? And have to answer no, because that would defeat the purpose. And secondly, because my colleague Matt Miller needs my blood and it's more convenient to get it before Christmas. So those are my 2 reasons for getting vaccinated early. But one of the things that people have shown is healthcare providers stop offering flu shots by December because they think it's done. Where in truth, your patients would be best served if you were getting them vaccinated in January, February. So that's another way to optimize uptake, is to continue offering them.
But the one last question. No. Okay. Well, then we bring this round to a formal vote, and thank you, Dawn, most sincerely for an excellent presentation.